Okay, good afternoon, everyone. Today I will talk about thyroid eye disease. We will go through these objectives, starting with introduction, then epidemiology, and a few slides about pathophysiology, then clinical presentation, diagnosis, management, prognosis, and then conclusion. Okay. Graves' disease is an autoimmune thyroid disease classically characterized by a clinical triad consisting of hyperthyroidism, diffuse goiter, and thyroid eye disease, which also referred to as Graves' ophthalmopathy or thyroid associated ophthalmopathy. This disorder is immunologically mediated condition that classically involved humoral immune system. Thyroid eye disease is originally associated strictly with Graves' disease, but has also been noted in Hashimoto thyroiditis, as well as in the absence of a thyroid dysfunction. While symptoms are typically bilateral, they are often asymmetric. The most common presenting signs are periorbital edema, eyelid retraction, eyelid lag in down gaze, restrictive strabismus, and compressive optic neuropathy. The disease course of thyroid eye disease does not always coincide with thyroid activity or the treatment of underlying thyroid dysfunction. In regard to epidemiology, thyroid eye disease is the most common cause of both bilateral and unilateral exophthalmos and has a higher prevalence in women than men. Both men and women demonstrate a bimodal pattern of age of diagnosis, range between 40 to 45 and 60 to 64 years in women, and 45 to 49 and 65 to 69 years in men. The median age of diagnosis is 43 years for all patients, with a range from 8 to 88 years. Risk factors for thyroid eye disease include age, more than 50 years has worse prognosis, gender, more common in female, ethnicity, family history. A positive family history of thyroid eye disease is noted in 61% of thyroid eye disease patients. Thyroid dysfunction and history of radioiodine therapy and smoking. Smokers are twice as likely to develop Graves' disease in general, and smokers who have Graves' disease are 7.7 times more likely to develop thyroid eye disease compared to non-smokers with Graves' disease. In regard to pathophysiology, development of thyroid eye disease is centered on inflammation of orbital tissue via stimulation of the orbital fibroblast. Remember the fibroblast. Orbital fibroblasts are unlike other fibroblasts in the body, in that they express CD40 receptors, which are normally found on B cells. When T cells interact with CD40 receptor on orbital fibroblast, the orbital fibroblasts produce pro-inflammatory cytokines. This leads to the synthesis of glycosaminoglycans and hyaluronic acid. Upregulation and deposition of glycosaminoglycans lead to orbital tissue edema. Orbital fibroblast can differentiate it into adipocytes or myofibroblasts, and this is important to understand the type 1 and type 2 of thyroid eye disease. Why? Because if the fibroblast differentiated into adipocytes, that explains the fatty hypertrophy of orbital tissue found in thyroid eye disease, which characterized by extensive orbital adipose tissue proliferation and deposition, which more commonly leads to compressive optic neuropathy, as in type 1 thyroid eye disease. But if fibroblast differentiated into myofibroblast, then this explains another variant of thyroid eye disease that manifests primarily with muscle enlargements and more commonly leads to restrictive myopathy, as in type 2 thyroid eye disease. So in clinical presentation, the thyroid status of a patient presenting with thyroid eye disease is quite variable, but 90% associated with hyperthyroid, 6% with euthyroid, 3% with Hashimoto thyroiditis, 1% hypothyroid. This is generally in worldwide, but I do believe that euthyroid status with thyroid eye disease is quite common in our region. 80% of patients experience thyroid eye disease within 18 months prior to or following endocrine disease. However, thyroid eye disease can present long before or long after the initial presentation of thyroid disease. It is important to know that thyroid eye disease is a self-limiting disease and may present in one of two stages, active or inactive. The active phase lasts for 1 year in non-smokers and 2 to 3 years in smokers, and has a recurrence rate of 5 to 10%, but is less likely to recur after 18 months of inactivity. The inactive phase follows spontaneous resolution of the active phase. Okay, the most common presenting sign of thyroid eye disease is upper lid retraction in 90% of patients. And the pathophysiology or the cause of that is multifactorial. So it can be due to increased sympathetic tone acting on molar muscle, or contraction of the levator palpebrae superioris, or scarring between the lacrimal gland and the levator palpebrae superioris. Exophthalmos is the second most common sign associated with thyroid eye disease in 60% of patients. Eyelid lag in 50% of patients. Static dysfunction in which the upper eyelid is elevated in relation to the globe while in down gaze. Restrictive extraocular myopathy in 40% of patients. Inferior and medial rectus muscles are commonly affected, leading to hypotropia and esotropia respectively. Pain with eye movement, 30% of patients affected, which characterized as dull, deep orbital pain. Optic nerve dysfunction, which is the most severe sign of thyroid eye disease, from compressive optic neuropathy in 6% of patients can be affected. The compression over the optic nerve can be due to enlargements of the recti muscles and increased volume of periorbital tissue within the bony orbit. It presents with dyschromatopsia, decreased vision, and or visual field. Exposure keratopathy, secondary sign due to lag of thalamus from eyelid retraction and or exophthalmos that predispose, as you know, the cornea into infection, which leads to ulceration, endophthalmitis, and perforation. Chemosis and conjunctival injection is a sign of active inflammation caused by congestion of the orbital tissue and more pronounced at the site of the rectus muscle insertion. Okay, there are several signs or name of signs associated with thyroid eye disease, and I'm going to present the most common one, starting with Kocher sign. Kocher sign is increased lid retraction with visual fixation that gives the patient staring look, as you can see in this figure. The figure below is Dalrymple sign, which simply is eyelid retraction secondary to thyroid eye disease. Okay, von Graefe sign is upper lid lag on down gaze, as you can see in this figure. Boston sign is jerky movement of upper lid on down or horizontal gaze. I'm going to show you this video. I hope that it will work. So just notice when the patient blink, see the jerky movements. Okay, so in terms of diagnosis, in addition to the clinical presentation of thyroid eye disease, there are several classifications which are important to diagnose the patient in terms of activity and severity. And these are the five most widely accepted and used classifications: NOSPECS, VISA, quality of life, clinical activity score, European group on Graves' orbitopathy. The most commonly used and widely accepted one are the last two, and I'm going to explain each one briefly. Okay, NOSPECS is the abbreviation is stand for N for no signs or symptoms, O for only signs, S for soft tissue involvement, P for proptosis, E for extraocular muscle involvement, C for corneal involvement, and S for sight loss. As you can see in the table here with the grades for each element. So it uses clinical characteristics at presentation to grade the sign and symptoms of the disease, but NOSPEC system fails to define the stage of orbitopathy. Is it active or inactive? That's why it is not commonly used. VISA, introduced by Dr. Dolman and Dr. Rootman in 2006, grades severity and activity for both subjective and objective measures of thyroid eye disease, as you can see here in this form. But the limitation that it takes so long time in the clinic to evaluate each patient of thyroid eye disease for each element of this classification. Again, VISA is the abbreviation of VISA. V stands for vision, I for inflammation, S for strabismus, and A for appearance. The third one is quality of life, and this is a simple questionnaire that provides valuable insight into the impact of thyroid eye disease has on a patient and the efficacy of the treatment. Okay, this is one of the most commonly and important classification that used to identify the activity of the patient. So it was developed by Moritz et al. To identify patients who are more likely to respond to corticosteroid and is based on disease activity. As you can see here in this figure, the first 7 elements are used for initial assessment. So pain with eye movement, pain with wrist, eyelid swelling, eyelid erythema, conjunctival redness, and conjunctival chemosis, inflammation and swelling of the caruncle. So 3 out of these 7 elements was found to correlate with active thyroid eye disease in the first visit. In the follow-up visit, 1 to 3 months after the initial visits, there are 3 more elements has been added, which are increased of proptosis more than 2 millimeter, or decreased in uniocular excursion in any one direction more than 8 degree, or decreased vision in one Snellen line. So 4 out of 10 considered as active in the follow-up visit. Okay, the last one in the classification is this UGOGO classification. It is a valuable research tool, and there are several schemes of 4 classifications under umbrella of the European group. This is one of the simple classification under UGOGO that used for severity, and they grade the severity into 3 parts: the mild, moderate to severe, and sight threatening. The mild is simply has mild retraction less than 2 millimeter, or mild soft tissue involvement subjectively, or exophthalmos less than 3 millimeter above normal, or no diplopia. So this is considered as mild thyroid eye disease. Moderate to severe, if there is lid retraction more than or equal 2 millimeter, moderate or severe soft tissue involvement, exophthalmos more than or equal 3 millimeter above normal, or diplopia. And the sight threatening, as you all know, that if there is optic nerve compression or corneal CED. Okay, in terms of laboratory workup, there are several lab workup can be done in thyroid disease generally and in thyroid eye disease, but the first two are the most important one, and I'm going to explain each one briefly. So the first one is thyroid function test, which includes TSH and T3 and T4, thyroid stimulating immunoglobulin, TSH receptor antibody, thyroid peroxidase antibody, and TSH binding inhibitor immunoglobulin. So why a thyroid function test is important? Because it has the highest sensitivity and specificity of any single blood test used to evaluate hyperthyroidism, and should be used as initial screening test for suspected thyroid dysfunction. TSI, why it is important? Because it strongly correlates with thyroid eye disease clinical activity and severity. And a positive association has been demonstrated with elevated initial TSI level and the developments and progression of the thyroid eye disease. The last three lab tests usually ordered by the endocrinologist, and briefly the TRAB used to detect antibodies can be useful when the diagnosis of the Graves' disease in general is uncertain. Thyroid peroxidase antibody, as you know, peroxidase is an enzyme that converts T4 to T3, and if a positive result seen, it's usually means that there is a previously attack on the thyroid, as in chronic thyroiditis, but also can be seen in other autoimmune disease. TSH binding inhibitor immunoglobulin is valuable in hypothyroidism. Okay, when we are talking about imaging, we mainly mean CT scan and MRI. Why? Because orbital ultrasound and Doppler have limitations in thyroid eye disease compared to these two modalities. So due to its widespread availability and rapid image result, the diagnosis is often first made on CT scan. No contrast usually needed. CT scan, as you know, is better for orbital bone evaluation in case if we need a surgical plan, and MRI is better for soft tissue involvement and to rule out other differential diagnosis. Okay, typical radiological finding. One of the most important finding is proptosis. And how can we know there is a proptosis in imaging? We have to measure the distance between the anterior aspect of the cornea and interzygomatic line. I hope that my mouse here is visible to you. So from the cornea to the interzygomatic line. If the distance is more than 21 millimeter or asymmetry greater than 2 millimeter between both globes, that's highly suggestive of proptosis. And other method is measuring the distance between the interzygomatic line and the posterior sclera. So less than 1/3 of the globe behind this line is also suggestive of proptosis. Okay, the second typical finding, radiological finding, is enlarged extraocular muscle and the fusiform enlarged of recti muscle belly with sparing of tendon is one of the typical finding. The most commonly enlarged recti muscles are variable in literature, but the most widely accepted sequence are inferior rectus, followed by medial rectus, then superior rectus and levator complex, and lateral rectus. Other finding is infiltration of fat. As you can see here, the muscle is not enlarged, but there is a fat predominance. And in this type, inferotemporal fat removal, orbital decompression can be safe and effective, which can reduce at least 2 millimeter of proptosis, depends also on amount of fat removal. Okay, what are the differential diagnoses of thyroid eye disease? Non-specific orbital inflammation, carotid cavernous fistula, orbital tumors, granulomatosis with polyangiitis, IgG4 related disorder. And each one has its special history and examination, and also lab workup, so you can rule in or rule out compared to thyroid disease. Okay, when we are talking about management, there are general treatments that should be applied to all thyroid eye disease patients. And the most important one, and the first one, is to control the thyroid hormone. The patient should be referred to endocrinologists to control the thyroid hormone. The second one is stop smoking if the patient is a smoker. Why? Because the cyanide that contained in cigarette smoke is converted in the body to thiocyanate, which act as an anti-thyroid agent, inhibit iodine uptake, increases iodine excretions, and inhibit thyroid hormone synthesis. Decreased salt intake, head elevation, cold compressors, as all of you know, can reduce water retention and orbital edema. Eye lubrication and sunglasses used to decrease photophobia and dryness. So all these elements should be applied to all thyroid eye disease patients. Okay, before moving to the details of each treatment, I would like to show you this, one of the most important curve in thyroid eye disease condition is Rundle's curve. And he explained that the early initiation of treatment is crucial in diminishing the final severity of disease manifestation. Treatment initiated during the early months of the active inflammatory phase has been shown to be most effective. But if the initiation of therapy done in the final months of active inflammatory phase, it has little effect on the final outcome of the disease. Once the chronic fibrotic stage has set in, treatment options become more limited and become primarily surgical. It is important to realize that each thyroid eye disease patient has a unique presentation, often requiring different treatment regimens: steroid, selenium, biologic immunomodulators, orbital radiotherapy, and surgery. Corticosteroids are still the mainstay of treatment in thyroid eye disease. And the benefit derived from corticosteroid administration is due to anti-inflammatory and immunosuppressive effects. And when we compare oral steroid with a dose of 60 to 100 milligram daily to IV steroid with usual dose regimen of 12 weeks period, 6 weeks of 500 milligram weekly, and then another 6 weeks of 250 milligram weekly, we can see here that the IV steroid is more effective and less side effects. Local subconjunctival and periocular injection of triamcinolone acetate may be considered when systemic glucocorticoids are absolutely contraindicated. Selenium. When taken regularly for 6 months to 1 year, selenium has shown to exert significant benefits in patients with mild non-inflammatory orbitopathy. In biologic immunomodulators, mycophenolate mofetil reduce proliferation of B and T cells of the immune system and used for active moderate severe thyroid eye disease. Azathioprine is a chemotherapeutic agent that inhibits DNA synthesis. Tocilizumab blocks interleukin 6 and may reduce disease activity. And the usual dose is 8 milligram per kg IV monthly for at least 4 months. Is usually helpful in steroid resistant patients. Rituximab, it targets CD20 on B cells and used in only, or should be used in early stage if the diagnosis made within 12 months, within 12 months period. and used also for a moderate to severe thyroid eye disease. Infliximab, adalimumab, etanercepts all work on blocking the tumor necrosis factor and may help in severe thyroid eye disease who fail in steroids and decompression. Teprotumumab is a new medication bombing nowadays and has FDA approval to treat thyroid eye disease. It works on human monoclonal antibody against the insulin growth factor 1 receptor. The usual dose is 10 milligram per kg IV in the first week, and then 20 milligram per kg IV for 7 more weeks. Used for active, moderate, severe thyroid eye disease with overall good response reaching 80%, but you should know that around 12% of patients experience temporary hearing loss. And also in recent publications, there are some patients developed a permanent hearing loss. Orbital radiotherapy can be used alone or in conjunction with corticosteroids, considered as effective second-line treatment for moderate to severe and active Graves' orbitopathy in combination with glucocorticoids. It is effective in compressive optic neuropathy, ocular surface and periorbital tissue inflammation, orbital congestion, strabismus and ocular motility deficits, but not used in proptosis and eyelid retraction. The contraindication, it is in microvascular retinopathy, increased risk of cataract, as you know, and tumorigenesis. Thus, orbital radiotherapy is typically avoided in patients younger than 35 years. Orbital decompression can be bone, fat, or both, can be used in sight-threatening condition after failed IV steroid treatment, but mainly used to reduce proptosis. Generally, if we decompress two walls, that will reduce proptosis by 3 to 5 millimeter, and 3-wall decompression can reduce proptosis by 6 to 8 millimeter. 4 walls decompression can reduce proptosis by 11 to 14 millimeter. Okay, so this is a comprehensive review about the treatment of thyroid eye disease. Now we'll talk about roadmap to manage thyroid eye disease case. So any patient with thyroid eye disease come to you in the clinic or ER. So the most important thing is we have to know about the activity and severity. And in terms of activity, we prefer to use the clinical activity score based on the elements that have been discussed earlier. So we can know that this case is active or inactive. And the second thing is the severity by using the UGOGO classification, so we can know which grade of the patients, mild, moderate to severe, or sight-threatening. And based on that, we can conclude each case and tailor the treatment for each patient. So if we have active sight-threatening thyroid eye disease, so we'll admit the patient and start IV steroid 1 gram for 3 days. And if there is no response, we can repeat the course or do urgent orbital decompression within 1 to 2 weeks. If we are dealing with active, moderate, severe thyroid eye disease, we can start the usual treatment of IV steroid 500 milligram per week for 6 weeks, then 250 milligram per week for another 6 weeks with a total dose of 4.5 gram. If no response, we can prolong the course up to 8 gram maximum in one period. A recent UGOGO 2021 guideline, recently they added mycophenolate mofetil plus the IV steroid as a first-line therapy for active, moderate, severe thyroid eye disease. What are the second-line treatment for active, moderate, severe thyroid eye disease? We can increase the dose of IV steroid into 750 milligram per week, but not exceeding the 8 gram per cycle. Or we can use oral steroid combined with cyclosporine or azathioprine. Orbital radiotherapy combined with steroid, teprotumumab, rituximab, and tocilizumab. Okay. If we are dealing with active but mild thyroid eye disease, in addition to the general treatment and controlling the risk factors that have been discussed earlier, selenium with 200 microgram daily for 6 months will improve eye manifestations and usually prevent progression to more severe form. If we are dealing with inactive thyroid eye disease, then we can consider rehabilitation surgery. If the patient's bothered with the proptosis, then we can do orbital decompression as a first surgery, then followed by strabismus, if any, and final treatment is, or final surgical plan is eyelid. And that can be considered only if euthyroid status and inactive stage for at least 6 months is achieved. Okay, so what is the prognosis of thyroid eye disease? Again, it is a self-limiting disease with patients moving from active to quiescent phase within 1 to 3 years with 5 to 10% risk of recurrence. Treatment for thyroid eye disease should start at the time of diagnosis, as treatment becomes less effective as the disease progresses from early acute phase to the chronic quiescent phase. Approximately 20% of patients with thyroid eye disease undergo some type of surgical intervention. In one study, 13% of patients with thyroid eye disease had eyelid surgery, and around 7% need orbital decompression. So in conclusion, thyroid eye disease is immunologically mediated disease and associated mainly with hyperthyroidism, but can be seen in euthyroid status. Eyelid retraction and exophthalmos are the most common clinical signs, but optic neuropathy is the most severe finding in 6% of patients. Diagnoses are made by history, examination, laboratory evidence, and typical radiological finding. Controlling thyroid hormone and smoking cessation are two important factors that need to be addressed. Treatment is mainly depends on clinical activity and severity. Steroid is the mainstay of treatment in thyroid eye disease generally. Biologic immunomodulators and orbital radiotherapy can be considered as second-line therapy. Thank you.